Aerobic endurance training adaptations are influenced by a blend of external conditions and individual characteristics. These factors shape both the immediate responses and the long-term physiological changes that take place during training. Now, let's look at these factors from environmental conditions like altitude and oxygen availability to lifestyle choices, genetic potential, age, and sex. Training at high altitudes, typically above 3,900 feet or 200 meters, presents unique challenges for the body due to reduced oxygen availability in the air. When oxygen levels drop, the body initiates a series of rapid responses to compensate. One of the first adjustments is increased pulmonary ventilation, essentially hyperventilation, both at rest and during exercise. Initially, this means breathing faster to bring in more oxygen. Over time, with prolonged exposure, the tidal volume or the amount of air taken in per breath also increases, allowing even greater ventilation. To meet the muscles, oxygen demands, cardiac output at submaximal intensities, exercise levels below maximum effort can increase by 30 to 50% compared to sea level. This is primarily achieved by a higher heart rate, as the stroke volume or the amount of blood pumped per beat tends to remain unchanged or may even slightly decrease. With long-term exposure to altitude, the body makes deeper adaptations. One significant change is an increase in red blood cell production, leading to a rise in hemoglobin concentration and hematocrit, the percentage of red blood cells in the blood. This increase in red cell mass enhances the blood's oxygen carrying capacity, compensating for the reduced oxygen available in the environment. So muscle adaptations also occur. Capillary density within muscle tissues increases, as does mitochondrial density, which improves oxygen delivery and utilization at the cellular level. These structural changes make the muscle better suited to perform with less oxygen, a crucial advantage at altitude. Furthermore, the body adjusts its acid-base balance. Hyperventilation reduces carbon dioxide levels, making body fluids more alkaline. To counter this, the kidneys excrete bicarbonate ions, helping to stabilize pH levels. These adaptations usually require about 3 to 6 weeks at moderate altitudes, around 200 to 3,000 meters, to achieve optimal acclimatization. Even with these adjustments, performance may still be slightly compromised compared to sea level conditions. For athletes, understanding and planning for these altitude adaptations is essential for training and competition success. Another external factor often considered for enhancing aerobic performance is hyperoxic breathing, breathing oxygen-enriched air. The idea here is that breathing air with a higher oxygen concentration might increase the oxygen available to muscles, potentially enhancing recovery or performance during or after exercise. So in theory, this could help by increasing the oxygen content in the blood, thereby improving the oxygen supply to working muscles. However, for healthy individuals at sea level, hemoglobin is already nearly fully saturated with oxygen, between 95% and 98%, leaving little room for improvement. While there is some divided research suggesting that hyperoxic breathing might be beneficial in specific cases, particularly at high altitudes or under conditions of severe oxygen deprivation, the exact mechanisms remain unclear. Consequently, the actual performance benefits of hyperoxic breathing are still a topic of debate among scientists and athletes alike. The negative impact of smoking on aerobic performance is well documented. Smoking increases airway resistance, making it harder to breathe, especially during exercise. Nicotine in cigarettes constricts bronchioles, the small airways in the lungs, and smoke exposure leads to fluid buildup and swelling within the bronchial passages, further restricting airflow. Moreover, smoking paralyzes the cilia, tiny hair-like structures that line the respiratory tract and normally help clear debris and fluids. This paralysis prevents the lungs from efficiently clearing mucus and foreign particles, leading to blockages and making breathing even more difficult. One of the most harmful effects of smoking is caused by carbon monoxide, a component of cigarette smoke. Carbon monoxide binds to hemoglobin with much greater affinity than oxygen does, forming a compound called carboxyhemoglobin. This reduces the blood's oxygen carrying capacity, leaving less oxygen available for the muscles during exercise. Smokers therefore often experience reduced maximal exercise capacity and higher heart rates and blood pressure during exertion as their bodies work harder to deliver limited oxygen to working muscles. The impaired oxygen delivery significantly hinders aerobic endurance. Blood doping is a practice used to artificially increase red blood cell levels, thereby enhancing oxygen carrying capacity and improving aerobic performance. This can be done by blood transfusions, either using the athlete's own blood, autologous, or donor blood, allogeneic, or by administering synthetic erythropoietin or EPO, a hormone that stimulates red blood cell production. The potential benefits of blood doping are well documented. It can increase maximal oxygen uptake, known as VO2 max, by up to 11%, allowing athletes to perform at higher intensities for longer durations. At submaximal levels, athletes benefit from decreased heart rate and blood lactate levels, along with a higher blood pH. This makes performance more efficient and allows athletes to sustain effort without accumulating fatigue as quickly. In environmental stress situations, such as high altitude, blood doping can mitigate the adverse effects by boosting oxygen availability. Similarly, in hot conditions, the increased blood volume helps with thermoregulation, allowing more blood to be directed to the skin for cooling without sacrificing oxygen delivery to the muscles. However, the health risks associated with blood doping are serious. Elevated hematocrit levels make the blood more viscous, increasing the risk for life-threatening events like stroke, heart attack, and pulmonary embolism. EPO use can also lead to high blood pressure, flu-like symptoms, and elevated potassium levels in the blood. While the use of modern medical techniques has reduced some risks, the ethical and health concerns surrounding blood doping remain significant. Genetics play a major role in determining an athlete's potential for aerobic endurance. Each individual has a natural ceiling or upper limit for physiological adaptations, influenced by factors like cardiovascular efficiency, muscle fiber composition, and overall aerobic capacity. As athletes approach their genetic limits, improvements become smaller and harder to achieve. For elite competitors, even minute gains can be critical, so understanding and working within one's genetic potential is essential for maximizing performance without pushing the body to harmful extremes. Age and sex are important factors influencing how the body adapts to aerobic endurance training. In adults, maximal aerobic capacity declines with age, primarily due to reductions in muscle mass, known as sarcopenia, as well as strength losses and an increase in body fat. These changes lead to a natural decrease in aerobic power as we grow older. Sex-based differences in aerobic capacity are also notable. On average, women have aerobic power values that range from about 73% to 85% of those in men, a gap largely attributed to body composition differences such as higher body fat percentage in women, lower hemoglobin levels, and smaller heart and blood volume compared to men. Despite these differences, both men and women benefit similarly from aerobic training in terms of improved cardiovascular and respiratory efficiency. Endurance training brings similar adaptive benefits, although the baseline performance metrics may vary between sexes. Ultimately, these external and individual factors, altitude, oxygen availability, smoking, blood doping, genetic limits, age, and sex, interact to shape an athlete's response to aerobic endurance training, while some factors like altitude and genetics require specific adaptations. Others, like smoking, create obstacles that impair performance. Blood doping may offer a short-term advantage, but the ethical and health risks are high. Understanding these influences allows for a more tailored scientific approach to endurance training, ensuring that athletes can reach their full potential safely and effectively. Each factor highlights the complexity of the body's adaptation to endurance training, showing us just how intricate and responsive human physiology is to our environment, habits, and inherent traits. Overtraining syndrome, often referred to as OTS, is a critical issue for athletes who aim to optimize their performance. While systematic training programs are fundamental to achieving peak athletic success, a balanced approach that incorporates sufficient recovery is equally important. When training intensity and volume exceed recovery capacity, athletes are at risk of overtraining, a state that can severely compromise both performance and overall well-being. Despite significant research on overtraining syndrome, defining, diagnosing, and treating it effectively remains challenging and is the subject of ongoing debate. In response to these challenges, the European and American Colleges of Sports Medicine published a joint consensus statement addressing overtraining syndrome. Drawing from the work of researchers such as Halson and Urhausen, the consensus statement aims to provide consistent terminology and markers for overtraining syndrome. According to this consensus, overtraining is a dynamic process which can manifest as either functional overreaching, non-functional overreaching, or full-blown overtraining syndrome, depending on the duration and severity. Functional overreaching refers to a short-term deliberate increase in training intensity that temporarily reduces performance. The goal of functional overreaching is to trigger a performance boost through a process known as supercompensation. For instance, athletes may engage in intense training sessions in the weeks leading up to a competition, followed by a gradual reduction in training intensity or tapering to allow the body to fully recover and maximize performance during the event. Non-functional overreaching, however, occurs when training loads are too high relative to recovery, leading to stagnation or decline in performance. Unlike functional overreaching, which is resolved in a matter of days or weeks, non-functional overreaching can take weeks to months of recovery before the athlete returns to prior performance levels. In this case, the intended benefits of overreaching are not achieved, and the athlete may experience prolonged fatigue, mental exhaustion, and reduced motivation. Overtraining syndrome represents the most severe end of the spectrum and occurs when the body experiences chronic stress without adequate recovery over an extended period. The consequences are profound, with performance dramatically reduced, and recovery can take several months or even longer. Overtraining syndrome is associated with numerous physical and psychological symptoms, including persistent fatigue, irritability, disrupted sleep, and reduced immune function. Studies suggest that approximately 10% of collegiate endurance athletes, such as swimmers, experience either non-functional overreaching or full overtraining syndrome during their training careers. The cardiovascular system often displays some of the first signs of overtraining syndrome. Athletes with overtraining syndrome may experience unusual heart rate responses, with resting heart rate either increasing or decreasing based on individual physiology. Another key indicator is reduced heart rate variability, which reflects a shift in autonomic nervous system balance, suggesting either reduced parasympathetic rest and digest activity or increased sympathetic fight or flight activity. Additionally, overtrained athletes may exhibit reduced maximum heart rates during intense exercise, indicating that the heart is not able to reach its peak output. Submaximal exercise heart rates, those measured during lower intensity activities, also tend to decrease. While this may appear to indicate improved efficiency, it is often a sign that the cardiovascular system is under stress. Although resting blood pressure usually remains stable, intense training loads can increase diastolic blood pressure, adding strain to the cardiovascular system over time. Biochemical markers provide further insights into overtraining syndrome. One such marker is creatine kinase, an enzyme that rises in response to muscle damage. Elevated levels of creatine kinase in the blood suggest that muscle tissue has been strained beyond its capacity to repair itself effectively. Interestingly, lactate levels, which usually rise with training intensity, often remain the same or decrease in overtrained athletes, suggesting a blunted metabolic response to exercise. Furthermore, muscle glycogen stores, essential for sustained energy during training, tend to diminish with prolonged overtraining, potentially contributing to feelings of fatigue and poor performance. Interestingly, blood lipid and lipoprotein levels typically remain unaffected by overtraining syndrome. However, reductions in muscle glycogen and changes in energy substrates indicate a shift in the body's metabolic state under the stress of chronic overtraining. The endocrine system, responsible for regulating hormones, undergoes significant changes with overtraining syndrome. In men, total testosterone levels often increase initially with higher training loads, but with chronic overtraining, these levels decline. Free testosterone, which is not bound to proteins and is more readily available for cellular functions, also decreases. This reduction in free testosterone levels is independent of changes in sex hormone binding, globulin levels, and is not regulated by the pituitary gland, as luteinizing hormone levels remain stable. Another useful marker for overtraining syndrome is the testosterone to cortisol ratio, which provides insights into the body's anabolic building versus catabolic breaking down balance. In athletes experiencing high training volumes, this ratio typically decreases or remains stable, with some studies noting reductions of between 5 to 50%. A decrease of 30% or more in this ratio is often considered a potential marker for overtraining syndrome, reflecting a state in which the body is breaking down more than it is building up. Overtraining also affects the release of growth hormone, primarily due to impaired hypothalamic function. While changes in hormone levels often accompany overtraining, it remains unclear whether these alterations directly cause performance reductions. Catecholamines, including epinephrine, norepinephrine, and dopamine, which are involved in the body's stress response, are also sensitive to overtraining. Alterations in baseline levels of these hormones have been observed in overtrained athletes, especially runners, and are often correlated with self-reported fatigue and other symptoms. Efforts to identify reliable markers of overtraining syndrome are ongoing. An ideal marker would be sensitive to training load, unaffected by external factors, able to predict overtraining syndrome before symptoms fully develop, easy to measure, non-invasive, and affordable. Although no single marker meets all these criteria, several variables are currently used as indicators. These include decreased performance, reduced body fat percentage, lower maximal oxygen uptake, altered blood pressure, increased muscle soreness, depleted muscle glycogen, altered heart rate patterns, elevated creatine kinase levels, altered cortisol concentrations, mood changes, and reduced psychomotor performance. Preventing overtraining syndrome involves a multifaceted approach to training and recovery. Since the primary cause of overtraining syndrome is an imbalance between training intensity and recovery, structuring training with adequate rest is essential. Athletes should prioritize balanced nutrition, adequate sleep, and rest days. Coaches can support this by monitoring training volumes and intensities, maintaining accurate performance records, and adjusting programs when early signs of overtraining syndrome appear. A multidisciplinary approach involving not only coaches but also physicians, nutritionists, and psychologists can help athletes manage the physical and psychological stressors that may contribute to overtraining. External factors such as environmental conditions, heat, cold, altitude, lifestyle factors, sleep quality, stress, and even interpersonal issues can all compound the risk of overtraining, underscoring the need for comprehensive support. While overtraining syndrome is a result of excessive training, detraining refers to the partial or complete loss of training-induced adaptations due to insufficient training. Detraining is governed by the principle of training reversibility, which states that the benefits of training can diminish when the stimulus is removed. It is important to distinguish detraining from tapering, a strategic reduction in training volume aimed at peaking for competition. Aerobic endurance adaptations are particularly vulnerable to detraining due to their reliance on enzyme activity and cardiovascular efficiency. In trained athletes, maximal oxygen uptake can decline significantly within 4 weeks of detraining, with reductions even more pronounced after long periods without exercise. These decreases are primarily due to reductions in blood volume, stroke volume, and cardiac output, as well as increased heart rates during submaximal activities. To prevent serious detraining effects, athletes should maintain an active recovery program and engage in regular training, albeit at reduced intensity during off seasons or periods of low activity. Overtraining syndrome is a significant challenge in the field of sports and athletics, especially for high-performance athletes who push their physical limits. With numerous physiological systems impacted, including cardiovascular, biochemical, endocrine, and neurological, overtraining syndrome presents a complex and multidimensional set of symptoms. Early recognition of these symptoms alongside preventive strategies can help athletes maintain optimal performance without crossing the threshold into overtraining. Comprehensive training and recovery programs are essential, as is access to a dedicated support team that addresses both the physical and mental needs of the athlete. By integrating scientific knowledge and a holistic approach to training, athletes and coaches can work together to mitigate the risks of overtraining syndrome, allowing for sustained success and longevity in competitive sports.